Again, good morning, everyone. My name is Kasey Petika, and we're thrilled to welcome you to the EMSC NPRQI Collaborative Kickoff. Thank you for taking the time today to join our session. We're excited to begin this journey with you all. And as we get started, feel free to introduce yourself in the chat with your name, role, and organization if you haven't already. We'll be interactive throughout today's session, so go ahead and keep that chat open. And we will begin today with some acknowledgements and how this work is supported. So we would like to acknowledge that the Emergency Medical Services for Children Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. Additionally, NPRQI is supported by the Toyota Way Forward Fund, and the contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. A few housekeeping notes before we get started with today's session. Please know that we want this to be a safe and supportive space, so we encourage open dialogue, sharing successes and challenges, and asking questions. To help keep us organized, please submit your questions in the Q&A function at any time, and we'll pause along the way to save time at the end for questions. If you are comfortable, you can turn your camera on when asking a question. This helps us to connect. After the session, please take our feedback survey, and your input directly shapes future sessions. And if anything comes up later, you can reach us at collaboratives@emscimprovement.center. So now let's meet the team supporting you throughout this collaborative. I will introduce myself first. My name is Kasey Petika. I am located in Austin, Texas, and I serve as a program coordinator for this initiative. My role is to coordinate the collaborative's activities and to support you all in your quality improvement efforts. Again, this is another opportunity if you are just joining us, or if you haven't already, we would love to know who's joining us today, so please share your name and organization in the chat. So we will go ahead and start introducing our amazing team that will be working alongside you throughout this collaborative. We'll go ahead and have us get started with Dr. Kate Remick. Then I'll have each of our team members introduce themselves as well.
Great. Thanks so much, Kasey. Good morning and welcome all. So excited to be kicking off this Quality Improvement Collaborative. Thanks for your enthusiasm and for being here today. I am a pediatric emergency medicine as well as EMS physician in Austin, Texas at Dell Med School. I serve as co-director for the EMSC Innovation and Improvement Center and co-director for the National Peds Ready Project. Really excited for the work ahead. Thank you all for joining.
Yeah, we'll just go around. I'll have Dr. Desai go next.
Hi, everyone. My name is Sanya Desai. I'm a pediatric hospitalist at Dell Children's in Austin, Texas, but have spent a good amount of my career before this working as the only pediatrician on site at non-children's hospitals. So care deeply about the work you all are doing and really grateful to work with you. I serve as a data strategist for NPRQI, which is the platform for this collaborative. And so my role and where you'll see me throughout is helping you with entering data, interpreting it, and moving through QI using the data you've entered.
Next up on my list of squares, I have Dr. Saidinejad.
Yeah, hi, thank you, Kasey, and welcome everybody. I'm Saidinejad. I am a pediatric emergency medicine physician in Los Angeles, working at Harbor UCLA. I'm a member of the EIIC's executive core, and my specific area of subject matter expertise is pediatric mental and behavioral health. So this will be an area that I'll be working with you guys on. Very excited to be here, and thank you so much for being here. And so amazing to see such a broad range of hospitals throughout the country being represented in this amazing work. So thank you again.
And I'll hand things off to Dr. Chumpitazi.
Hi all, I'm Corrie Chumpitazi. I'm a pediatric emergency medicine doc by night and weekend and a research academician at Duke. And I've had the great pleasure of working with the EIC since the first iteration. And I get to work with Dr. Saidinejad and Kate and the crew on the Pediatric Pandemic Network as well. I love pain and sedation research and quality improvement. And so I will be leading the pain metric and very excited to work on that with you all.
Yeah, and then Dr. Jensen.
Hey everybody, I'm Aaron Jensen. I do pediatric surgery, trauma, and critical care at University of California, San Francisco and the Benioff Children's Hospital, Oakland. I'm the trauma domain co-lead for the EMSC Innovation and Improvement Center, and also the chair of the American College of Surgeons Quality Pillar for the Committee on Trauma. And I'm passionate about quality improvement in kids. My role in this project is really all about head trauma, workup, evaluation, management, and really quality improvement in head trauma. So whenever the head trauma topic comes up, you'll be hearing from me. Thanks for joining us today. This is really exciting.
Yeah. All right, next up I have Robin. Good.
Good morning, everybody. My name is Robin Goodman. I am a project manager for the EIAC and served as a pediatric emergency care coordinator in the Los Angeles County system for a little over 20 years. And my passion truly is just supporting pediatric emergency care coordinators and pediatric readiness initiatives across the United States.
So Robin. Next up I have Pradeep.
Yeah, hi. I'm Pradeep Chaudhary. I'm a pediatric emergency medicine physician at Children's Hospital Los Angeles in Los Angeles. And I am a clinician scientist with a focus on pediatric trauma and head trauma specifically. So I'll be sort of working on that domain with you all.
Thank you. And then we also have Erica Green.
Good morning, you guys. My name is Erica Green. I'm the Pediatric Trauma Program Manager at ECU Health Medical Center in Greenville, North Carolina. And I will be helping as a subject matter expert with the Head Trauma Collaborative. And we're very excited to participate and see what we can do with these projects moving forward.
Yeah. And then we also have Crystal Bartley.
Hi there, everyone. I'm Crystal Bartley, Assistant Director of Quality at Dell Med School. It's a pleasure to see everyone here today. I was actually part of the first iteration of this collaborative, so it is quite impressive to see that a lot of the original team members are still here, and we look forward to seeing the work that you do ahead. I'll be involved in some capacity helping you all with quality improvement intervention strategies and strategies to implement at your local sites. So good luck and congratulations, you guys.
Thank you all. Don't feel like I've missed anyone. So this is your support team, and please do not hesitate to reach out to any of us throughout the collaborative, as we're here to help you succeed in your work. Great. Now that you've met the team, I'd like to ask you to pause for a minute and imagine a scenario with me. It's late at night, and your 1-year-old daughter has not been feeling well all day. You're trying to sleep, but you hear her having a coughing fit in her crib, and you go to check on her. As you get nearer, you realize her breathing is labored, and you can hear she's really struggling for air in between coughs. You scoop her up into your arms, but she's not responding as you say her name, and you panic, and you can tell she is hot to the touch and feels clammy. You yell for your partner to call 911, and as you focus on your child, you probably do not stop to wonder or worry. Does the responding EMS agency have the right skills, equipment, protocols, or other resources they need to help her? If they take her to the hospital, does that emergency department have those skills, resources, or protocols as well? A child experiencing a health crisis is every parent or caregiver's worst nightmare. But every year, 35 million children and families need emergency medical care. While that's a significant number compared to adults, children's emergencies are relatively infrequent. This means that EDs and EMS agencies do not get as much experience with pediatric patients as they do with adults. In fact, 80% of EDs see fewer than 10 children per day, and 80% of EMS agencies treat fewer than 8 children a month. It's even rare that they treat a child with a life-threatening illness or injury. Faced with limited resources, EDs and EMS agencies tend to focus their attention on adults, patients they see the most. This means they might not have the pediatric-specific skills, resources, and protocols needed to respond to all types and severities of medical emergencies in children. Why do children need specialized care? Because they are not simply tiny adults. Children have thinner skin and higher metabolic rates. They have higher respiration and larger body surface area. These differences have significant implications. For example, children are more prone to drug dosing errors. And that's just the physical differences. Children may also have have differences from adults psychologically, developmentally, and socially. For example, small children can't articulate their symptoms the same way adults can, and they may experience more fear or anxiety around medical treatment. Children require pediatric-specific care that is tailored to them. And what does this look like in real time? Clinicians might not have the training to perform key pediatric procedures. They might not have the right-sized equipment for treating specific age groups. Even if they do, they might use it too infrequently that they cannot locate it quickly or do not realize the battery is dead. Or no one on staff is familiar with the technology. They might have the protocols and processes that take into consideration children's need, like maybe they're weighing and recording patients in pounds instead of more precise units, kilograms, which is crucial to avoiding medication errors. Or perhaps they have a mental health protocol for adults experiencing suicidal thoughts, but not for children who need a much different approach and support for follow-up. Of course, there are EDs that specialize in pediatrics. These pediatric-specific EDs are often located within children's hospitals. Serve a vital role in the emergency care system. But reality is most children live more than 30 minutes away from one of those EDs, and that's too far away in an emergency where minutes or even seconds count. What's more, in the tragic cases of a child passing away after a medical emergency, research shows that their death happens within an average of only 3 hours. That may not be enough time for a child to be treated at a general ED and then transferred to a special pediatric one. The bottom line is that children need every emergency department and every EMS agency in their community to be ready to take care of them, or what we call pediatric ready. To help us define what that means in practice, I'll hand things over to Dr. Kate Remick.
Great, thanks, Kasey. Hopefully everybody is here because you've already heard a little bit about pediatric readiness. You know what it is, but really just want to clarify that pediatric readiness is not about a team being ready to take on a child, but it's about the system being ready to serve the needs of the healthcare providers that are working in that system to support pediatric care. So pediatric readiness is really a system design framework. It involves 7 domains of focus. It certainly includes having equipment, supplies available, but also includes having patient safety mechanisms in place specifically for children, having quality improvement where we're looking back at the care provided, having policies, protocols, procedures, and the like, ensuring staff, yes, are maintaining competencies, and perhaps most importantly, ensuring that there's someone to really coordinate and oversee all those aspects of pediatric readiness. And that's how we ensure that regardless of where a healthcare team is working, that when a child comes into that ED, that they have all the tools, resources readily available to be able to support that child and their family. Next slide, please. So as Kasey shared, pediatric readiness is hugely important because most children and their families, when they have an emergency, they will go to the closest emergency department, the one that's right down the street, the one that has a big red sign that says emergency and speaks to them as meeting their particular healthcare needs. We know that the great majority of kids are not seen in children's hospital emergency departments. They come to community-based emergency departments, and most of those see fewer than 10 pediatric patients per day. And that means that we don't have a lot of opportunity in those facilities to see high-risk, low-frequency events. And oftentimes, in the absence of pediatric readiness, it becomes extremely challenging to be able to provide the best, most efficient and effective outcome for those children, and that is why pediatric readiness is so important. In these facilities, we know it can also be difficult to prioritize, even simple access to equipment and to access training. And hopefully during the course of this collaborative, we'll also be sharing some tools and techniques to help to support that. But most importantly, pediatric readiness is really about that system design and making sure that everything is in place and at your fingertips to be able to support you. So if it comes to, for example, peds resuscitation carts, you know exactly where they are. They're categorized the way you need so that you can respond quickly in those settings. Next slide, please. Some people have reported or expressed concern about, well, how expensive is it or how hard is it to become pediatric ready? And now we know over the last couple of years, there's been a tremendous amount of effort looking at the actual cost to be pediatric ready. When we break it down on a per patient basis, the actual cost to a facility to be pediatric ready is somewhere between $4 and $48 per patient. So regardless of your pediatric patient volume, if there were additional $4 to $48 charged per patient, that ED would have sufficient financial resources to ensure everyday readiness. And if we break this down more on a population basis and look at states and the population of children that live in those states, we know it to be less than $12 per child. And given the fact that there's such a potential impact on lives saved, we view this as a high return on investment. Next slide, please. So most importantly, we're all working towards the same vision. As many of you know, the National Pediatric Readiness Project is a joint effort between the Federal EMS for Children program, but in collaboration with multidisciplinary organizations, including the American Academy of Pediatrics, the American College of Emergency Physicians, the Emergency Nurses Association, and the American College of Surgeons Committee on Trauma. And the overarching goal of this effort is to ensure that all children have access to high quality emergency care, regardless of where they live. So rural and urban areas alike, our goal is to make sure that when we need emergency care, we can access the highest levels of care, regardless of where we are. Next slide, please. We know this is also really important in terms of outcomes. We now have studies showing that children who are seen in emergency departments that are pediatric ready have as much as a 76% decrease in mortality risk. And this is tremendous because overall, when it comes to children who come to emergency departments, we know that less than 1% of children actually succumb to their illness or injuries. And to be able to reduce that by as much as 76% really makes this a healthcare imperative. And we now know that there are over 2,000 children who unfortunately do succumb to their illness or injury every year in the United States. And if we were able to make every emergency department pediatric ready, we could prevent those deaths. There is a tremendous amount of work currently happening on the pre-hospital side in the world of EMS. There are now joint policy statement or guidelines on how to be pediatric ready in EMS systems, how to really integrate that into everyday practice, but also work is coming down the pipe to look at how it impacts patient outcomes in those settings, and certainly how we can really have a more integrated system where children are seen both in the EMS setting in a pediatric ready agency and then transported to pediatric ready EDs. And that's really a long-term goal for all of us. So next slide. The reason that we are all here and that we try to host these quality improvement collaboratives is that quality improvement is really one of the leading drivers of pediatric readiness. It is, this idea that we are looking back at the actual processes of care, the delivery of care that we provided to children to identify opportunities. In the majority of cases, we might have errors or opportunities or delays in care that don't result necessarily in sentinel events. And if we're engaged in quality improvement on a continuous, regular basis, we can identify those opportunities early, hopefully before they actually cause harm or prevent a serious adverse event for that child. And it really builds on what is already happening in the larger healthcare landscape. Certainly, the Joint Commission, the National Quality Forum, the Institute of Medicine, all have written up reports on the importance of quality improvement. We also see quality improvement as a cornerstone for stroke, trauma, STEMI centers. And all of this work in pediatric readiness really aligns with that same sort of framework of really ensuring that we're providing the best outcomes for these patients by adhering to evidence-based practice. Within the EIC, we particularly focus on quality improvement as well, because we know that by bringing people together, by networking and bringing evidence to your fingertips, that we can really transform our healthcare landscape on the order of 3 to 5 years, as opposed to on the order of like 15 to 20 years. So what we're really trying to do is accelerate healthcare transformation, specifically as it relates to pediatric emergency care, and it really forms the basis for all of our pediatric readiness efforts. Next slide, please. So high quality care is certainly not easy. It does require ongoing kind of assessment of how are we doing relative to this. And once you get the hang of it, I think it becomes much easier. But we also want to make sure that we have the tools and resources to support you. What I do want to highlight is back in the late 90s, 1999, 2000, the Institute of Medicine published this report called To Err is Human. And I suspect that many of you recall this report. In this report, they cited that some 90,000 people were likely dying every year in the United States from preventable medical errors alone. Shortly thereafter, there were subsequent reports, one that said the estimate is likely closer to 150,000. And up until right before COVID, there was growing awareness of preventable medical errors happening within our healthcare system, so much so that estimates were that preventable medical errors were the third leading cause of death right before the COVID pandemic hit. And so we know that because of some of the things Kasey mentioned earlier about children having more particular needs or considerations when it comes to anatomy and physiology, types of diseases they face, as well as developmental milestones, that children are actually at even higher risk than the general population for adverse medical events or preventable medical errors. And so we know every system, is designed to get the results that it gets. And what you're seeing here is something that in the graphic is something that Kasey mentioned earlier, which is, the average time to death for those children who have a high risk injury or a high risk illness is on the order of, less than 3 hours from the time of their initial ED visit. And we have a great opportunity to really prevent those deaths among patients who present to the ED by ensuring pediatric readiness and ensuring the best outcomes for those patients, overcoming these safety events and the like. Next slide, please. This is really just intended to be a sample roadmap for pediatric readiness. I hope that many of you are here because you've already heard a lot about this national initiative. Really, one of the first steps in the Pediatric Readiness Project is taking the Pediatric Readiness Assessment, which I suspect most, if not all of you, have done at some point over the last few years. The Pediatric Readiness Assessment is open access. It's on the EMSC Data Center website, which is pedsready.org. And once we take those assessments, we get a gap report, we see where there are opportunities for improvement. In many cases, it's identifying a leader or a PEDS emergency care coordinator. But once we have that, our next step is really about making improvements, driving improvements, and that's where quality improvement comes into place and what we're here to help support you all to do so that we can all have high levels of pediatric readiness in our facility and make sure that regardless of the child or the condition that they come in, that we're ready to meet their needs. Next slide, please. Quality improvement is also particularly important, not just because we're looking for opportunities to make improvements and prevent errors, but also has been associated with improvements in overall pediatric readiness. And it's not just small improvements. We're talking about 25-point average adjusted increase in pediatric readiness. What that means is if you took away the points in the PEDS Ready assessment that are associated with quality improvement, and of those remaining points, normalized it to 100, for those emergency departments that engage in pediatric quality improvement, we see an average 25-point increase in all of the other components of pediatric readiness. And it speaks to the value of quality improvement in driving the best outcomes for all of these systems of care, trauma, stroke, STEMI, but also most certainly pediatric emergency care as well. And that's really another impetus for these quality improvement collaboratives is we want to help you get there and we want to see the impact that you can make over time. Next slide, please. Over the last couple decades, there's been a tremendous amount of work on pediatric readiness and growing momentum, which is super exciting. Most of you are probably aware that the first National Pediatric Readiness Assessment that was kind of under that banner happened in 2013. But some of you may not know that there was actually a national assessment that happened about 20 years ago in 2003. It was not necessarily under the name the National Pediatric Readiness Project, but similar to all of these efforts that we're doing, it was based on those national guidelines from AAP and ACEP And because of that, we actually now can follow kind of 3 points over the last 20 years in terms of how we're promoting pediatric readiness. So that first national assessment in 2003 was critical, led by Marion Gauthier Hill and the other organizations. And at that time, the pediatric readiness score for our nation was 55. In 2013, the first time it was really presented under the banner NPRP, the median score across the US was 69. I think, we all felt growing improvements. We saw it. We knew there was a tremendous amount of engagement from frontline healthcare providers. But unfortunately, as COVID hit and the healthcare workforce took a significant hit, we didn't see as much of a gain in 2021 as we'd seen between 2003 and 2013. And the main reason for that was because of the loss of the PEC workforce, as many people were furloughed or repurposed or, unfortunately, left healthcare more broadly. So I think we have a lot of work to do, both here in this collaborative and also over the coming year. And if you go to the next slide, the last thing that I want to share is that we have our next National Peds Ready Project Assessment coming out. Some of you may know that the most recent revision to the Joint Policy Statement on Pediatric Readiness was just published today. If you haven't seen it, feel free to go to the ENA website, the AAP website, the Journal of Acute Care Surgery, the Pediatrics Journal. They're published in all 4 locations. You can see them now. Really excited to have the American College of Surgeons Committee on Trauma as a leading organization, which is new with this set of guidelines. But those were just published. And with that is coming the next national assessment, which will be launching on March 3rd of this year. If you're curious what's new in the guidelines, there is an upcoming webinar that's going to be held on February 12th. We'll post the registration link in the chat so that if you're interested in joining that, you can hear about some of the updates to the new joint policy statement. But we are continuing to provide support through the National Peds Ready Project Toolkit and Checklist, which are hosted on the EMSC Innovation Improvement Center website. We hope come March, all of you as part of this collaborative will join the national assessment period and take the assessment again, the 2026 assessment. And also, if you need any other support with PECs along the way, we're here to help with that too. We now have modules available to help support that. So really excited you're here. And with that, I'm going to turn it over to Saidinejad, who's going to speak about why these collaboratives are so important. So thanks.
Thank you so much, Kate. It's hard to go after Kate. She knows so much about this space, and it's just so exciting to be part of this group with you guys. So I'm going to talk briefly about really why I personally love the power of the collaboratives and why I think that it is such an amazing way that collaboratives can help really strengthen the hospital readiness in many, many different areas. Can I go to the next slide, please? So essentially, when I first heard about the collaboratives, the first thought I had was, is this really a competitive thing, or is it sort of like people working together? How is that going to work? Different hospitals with different amount of resources and different number of staffing. But what is really great about collaboratives is that it really doesn't matter. What it matters is that you have somebody who's interested in making a change for the better. And then working together, you move as much faster than you otherwise would. And again, this accelerated progress towards optimizing pediatric readiness can be accomplished just because you guys are all working together with different perspectives, different experiences, and you all have already solved different types of problems that others may not have thought about. So what it is, it's structured, it is team-based, and it allows you to come up with a specific quality improvement goal. I want to make something better. I want to, for example, get patients who come through the triage faster to a room, or I want to get discharge papers distributed faster. You pick a project that you want to work on. You have a multidisciplinary group of people in your team. Ideally, you have doctors and nurses and social workers and child life specialists and everybody working together towards this unified goal. And the idea is that you have your main goal is to have what is the most priority? What are some of the things that you can solve? And also not only that, but what are some things that are not so difficult to solve that might be lower hanging fruits? And then you get this small progress going, and then you share with others how you've succeeded, and then you share the resources that you have developed. And that's essentially what collaboratives do. They help you learn together. Next slide. So this one is a little bit of a more complicated slide, but this essentially talks about where the collaboratives, essentially kind of the concept and everything was developed for this. And this really comes from the Institute for Healthcare Improvement that has developed this breakthrough series model. The idea of that is you bring organizations together, and the goal is to achieve a rapid but really meaningful quality improvement by sharing your knowledge, testing evidence-based changes, using this PDSA cycle, which many of you guys are familiar with, and then spreading the successful ideas. And that way you're bridging the gap between what science and what research has already come up with and what we actually are doing in clinical practice. So the idea is that whatever best practice is out there, there is one, and we should be using that in our clinical practice. So as you can see on the right here, there's the schematic where you first choose your topic, then you assemble a group of experts to kind of address, okay, how are we going to solve this problem, developing some framework for it, putting together a planning group. Then you start doing the work, but it's not one specific product. It is a series of small trials and errors until you get to where you want to be. And then when you get to where you want to be, the next step will be, how am I going to continue this good work? How am I going to sustain it? And then how am I going to share it with others? And that's essentially what this process is, which we are going to be doing in this NPRQI, like many of you guys who've done previous ones have already noticed. Next. So again, as mentioned, this is looking at everything through quality improvement science. The goal is not for you to be perfect. The goal is for you to start where you are and make an improvement for the better. And you have to set some goals and say, I want to make 75% of all the patients who have their discharge order put in be actually discharged within 15 minutes of that discharge order. And you can put the goal of 75%, 50%, what have you. And also be aware that even the smaller changes that may not seem like much, they can add up and significantly improve the quality of care that your patients receive. So it is important to consider that we're not always thinking major fundamental changes, but even small changes that make lives easier. The other thing to consider is that this is more of a celebrating small victories. This is not about sending people benchmarks and saying you failed, you didn't make the benchmark, we are below what we need to be. It is more about celebrating the fact that we have moved the needle, we have gotten better, and realizing that this is not going to happen overnight. This is a very slow process, and you need to be in for the long haul. So it's a marathon, not so much of a sprint. Next slide. And then I think this is my final slide. So collaboratives are very important in the sense that they allow more people from different institutions to work together, learn from each other, help solve each other's problems, and knowing that there is a best way, there is a evidence-based way to practice and share those evidence-based resources that they have with each other. It is also a little bit of coaching, but a whole lot of peer learning. A lot of it is equal people working in different hospitals, having addressed problems that they have encountered, maybe faster than somebody else has, and that way they can share. Most importantly, find, identify, and support your pediatric emergency care coordinator, your pediatric champions, and make sure that they have what they need, because sustaining a pediatric champion and a pediatric emergency care coordinator, we know by evidence, has a lot to do with improving quality of care and readiness score. We also provide you with a dashboard to track your progress longitudinally. But again, this dashboard is just for a matter of you being able to track what you're doing. Again, it's not a punitive thing. It's not so that you can feel how you're not working as fast as you want, but it's more about tracking your progress. And it is very important to have measurable initiatives that you can achieve that goal by being able to measure it over time. And it is those little things that help overall increase the quality of care and ultimately save lives. Next, and I now pass it back on to Kasey to go through the focus areas that we're going to be having you guys participate in this NPRQI.
Thank you, Mel. The EMSC NPRQI Collaborative is designed to give every ED the flexibility to focus on what matters most for the patients you're seeing while providing support and resources. You'll choose one of our 4 clinical areas of focus: pain assessment, abnormal vital sign reassessment, suicide assessment and management, or head trauma, which utilize one or more of NPRQI's quality measures. Now let's take a closer look at why these specific areas were chosen. Each of these topics represent a critical component of pediatric readiness and has a significant impact on patient outcomes. Over the next slides, I'll have our subject matter experts break down each area and share the evidence or rationale behind their selection. Very briefly, as we go through these, think about which areas resonate most with your team's current priorities or challenges. I'll go ahead and hand things over to Dr. Chumpitazi.
Fantastic. Thanks, Kasey. So pain management pain assessment was chosen because clearly it's the most important of all your measures for the ED. Just kidding. But we do see that it's the number one reason that pain in general is the number one reason that children seek care. Over 50% of our kids come in with a pain-related condition. And so it's less managed well in kids than it is in adults. We're still working through those stigmas of that child. I can't give them any pain medication because then we won't be able to, the surgeon can't get their exam and we won't be able to examine the child. And so we are really excited to work on pain assessment. We've learned many great tips and tricks from the teams over the last couple collaboratives, including looking at integrating different kind of jet lidocaine or intranasal fentanyl into their programs as well. And for those that already have a fantastic pain assessment program, I think thinking about how do we do pain reassessment. For example, our hospital said we had a 99% compliance with reassessment, and we said that's not possible. They go to radiology, they go upstairs, they go other places. So we think pain's important, and we'd be delighted to work with you and your teams on this objective. I'll turn it on over to Mo.
Thanks, Corrie. Yeah, so as I mentioned earlier, I'm the one that is going to be working with whatever team ends up choosing suicide, as I'm the mental health person here. So suicide, one of the best ways to describe that is that when I did my residency and fellowship and loved being in the ED, I didn't expect to be able to have so much suicide and so much other mental health things coming through the ED. But bottom line is we're the safety net of the healthcare system. So everybody who doesn't know what to deal with, they are sending patients to the ED. So as a result of that, we have a tremendous number of presentations to the ED with young adults and youth who come in with mental health related problems. Suicide is one of the bigger one. As you guys may know, suicide is the second leading cause of death in children between the ages of 10 to young adult age of 24. And depending on what studies you look at, some go as high as 34. So the rate of presentation of suicide to the ED has increased by 2/3 from 2007 to 2021. And I bet you today it's even higher than that. And one of the things is that when we did the 2021 pediatric readiness assessment, of the hospitals that participated, only 73% of them reported that they have any kind of mental health policies there. And our current NPRQI dashboard, in terms of performance, we're only having 75% of all those suicides who need a suicide screening that are actually getting a screening, which means a quarter of them aren't. And last thing I want to say here is that in January of 2025, there was a recommendation by the American Academy of Pediatrics where many states have actually turned it into policy that every child or young adult, 12 and over, whatever the presentation to the ED may be, has to get a universal suicide screening. So because of that, number one, the fact that it wasn't something we were comfortable with. And the second is we have a lot of customers with that. And number three is that suicide is a major killer. So we need to have an ability to screen, not only screen, but figure out who's going to do assessment, provide ED-based intervention, and potentially safe discharge planning. So being able to participate in something at the minimum suicide screening would be incredibly helpful. So if you choose that, I'll be working with you on that and help you guys be prepared for an important topic. I'm going to pass it to Robin for the next one.
So I'm going to be working on abnormal vital signs, and abnormal vital signs are among the strongest predictors of pediatric deterioration, yet they often are normalized, overlooked, and not obtained. And so join us for a fireside chat on February 11th to explore the NPRQI abnormal vital signs measure and some simple strategies to improve reassessment, escalation, and team communication around vital signs. Session will focus on what works in busy emergency departments and how small changes can make a big difference for kids. Hand it over to you, Erin.
Thanks, Robin. I don't know why I always have to follow Robin. She does such a great job. So yeah, like I said before, I'll be working with you guys on the head trauma module. Everybody, I think, recognizes that kids bonk their heads, and that's one of the most common reasons they come to the ED. And, there's really a broad continuum of head injuries, very minor head injury, kids who hit their head but don't have anything wrong with them, and all the way to severe head injury. So this particular module is actually going to focus on both ends of the spectrum. Kids who come in that are actually very low risk for having intracranial hemorrhage, that we're probably doing harm by CTing them. It's thought that anywhere between 1 in 500 to 1 in 1,000 CT scans leads to a leukemia. Like, we give a kid leukemia by scanning their head. So really looking at appropriate indications for head CT, particularly in kids that don't need it. It's very easy to say, oh, they bunked their head, let's get a CT, but we're probably leading to morbidity because of that, and maybe even some mortality. Conversely, on the other end, how do we recognize severe injuries, and how do we track our time to transfer out? How do we make sure that we're measuring one of those very important vital signs that Robin talked about, which is Glasgow Coma Scale for kids who hit their heads, and reassessing Glasgow Coma Scale? Looking at the appropriate use of medications. Steroids are bad for TBI. Hypotonic fluids are bad for TBI, yet we all give half normal saline to a lot of kids. So really looking at a lot of these quality metrics around how we take care of kids with minor head trauma or major head trauma, and trying to integrate those into systems-based solutions to improve quality in your EDs. So really looking forward to this fireside chat and working with a group of you that are interested in improving care for kids with head trauma. Thanks.
Thank you all for pitching your clinical areas of focus and letting folks sort of start considering which of these areas feels most relevant or impactful for your organization as we move forward. As we mentioned earlier, there are opportunities in the coming months for you to hear from each of our subject matter experts in more detail on these areas of focus and help you get started on implementing those quality improvement projects. So more to come on that. But if you do foresee any challenges or any great opportunities to begin addressing these areas of focus, we look forward to discussing those with you. I'm going to go ahead and hand things over to Dr. Desai.
Hi, everyone. I am going to briefly chat with you all about NPRQI. And NPRQI is the platform that we will be using to enter and visualize data for this collaborative. Next slide, please. So NPRQI is a free platform that is entirely self-paced. And the goal of our platform is to enable you all to measure your performance on various metrics, benchmark them against other hospitals to identify where your gaps are, and then track your improvement over time. This platform is designed for folks who don't have experience with EHR electronic, data entry. They don't need informatics expertise. You don't need QI expertise. It's really for you and me, for frontline clinicians, folks that are wanting to make a difference in pediatric emergency care, but don't necessarily have some of those areas of expertise in QI or informatics. Next slide, please. This is just a visualization of what the framework is for NPRQI. So you will get login credentials to access our web-based platform. You will be asked to enter information on the pediatric encounter, really from the start to finish of the encounter. And then what the platform does is transform your patient level data into aggregate measures for your hospital. So it spits back, well, how does your hospital perform on the patients you've entered on these various measures? That allows you the opportunity to reflect on where your performance is, compare it to other hospitals, identify what makes sense for you to focus on, and then improve and track your improvement over time. Next slide, please. The quality measures in NPRQI have been vetted by a panel of national experts. We have 28 different measures. We've highlighted some here that correspond to the areas of focus for the collaborative. These are built into the platform, so you don't have to do any of the math for calculating them. All you have to do is enter your patient encounter data, and then you get your performance on these metrics. Next slide. This is an example of the table view in NPRQI. We have a list of metrics here. Some of them are affiliated with the collaborative. And what you can see here is that a hospital can look at their own performance and then compare it to how everybody else that has entered data in NPRQI is doing, and then how sites similar to them are doing. Once you've selected an area to focus on, it's also important while doing QI to look at how you are performing over time. If you did an intervention in Q1 of 2024, did your performance actually improve in a temporally associated, which means along the same time as the interventions? So I think that this is an opportunity for you to track performance and ensure that the interventions that you're doing are actually resulting in improvement. NPRQI does require manual data entry in order to view your performance. What we're asking is for a minimum of 10 patients' charts per time period to ensure that the confidentiality of each individual patient is kind of preserved, which means that in order to see any values on your table or any data points on your graph, you need at least 10 patients per data point in order to be able to see anything on NPRQI. We are asking that for your baseline performance, which is between now and March of 2026, that you enter a minimum of 30 patient charts. We ask that these are entered before the end of March, because viewing that baseline data will help you determine where you are at the start of the collaborative and also help inform where to focus. Beyond that, the ongoing data entry after March really is dependent upon your bandwidth, your ability, and as long as it's being entered in regular data intervals and meeting that minimum of 10 charts threshold, we can still help you interpret that data and improve your performance based on what you're entering. Next slide. I wanted to just briefly touch on the concept of data sampling. Because this is manual data entry, we are not asking you to enter every patient that enters your ED. That is a lot of time that would go towards data entry that is better served, focusing on the actual improvement aspects of this collaborative. But we also want to make sure that you are entering what we call a representative sample of patients into NPRQI, which means that we want to make sure that if you're only entering 10 charts in the month of January, that those 10 charts are as close to random as possible and that they reflect kind of the population of patients, and there isn't any bias in that. Next slide. And so what we recommend is for you to conduct a systematic sampling of patients, which means if you have 100 patients that are seen in your ED in the month of January, and you know you have the bandwidth to enter 10, we ask that you arrange your patients in a chronologic order and enter every 10th patient. This is kind of a simple way to ensure that you aren't introducing a biased sample of patients into the collaborative or into the data set. The other option would be to create a random sample generator, a random number generator to identify patients, but that just takes more work than is needed. What we don't recommend is for you to go in and cherry pick which patients you are entering into NPRQI, because that could mean that you are entering a type of patients that doesn't actually represent the whole population that is seen in your ED. You'll hear a lot more on this from me in future sessions, but just a little taste of how to enter data in NPRQI to get you started. Next slide.
So much. We do
Oh,
have
okay.
a question. We have
Casey.
a question for you in the chat.
Oh, yes.
So are we able to add data for all areas or just the ones we choose to concentrate on?
So what we recommend for the baseline data period is for you to enter to do a systematic sample for all children that are seen in your ED. A lot of times we have hunches or we have ideas of what we think we need to improve. But like many of our speakers brought up earlier, you really don't know where your gaps are until you look at them objectively. So unless you're a site that has already done PRQC with us or has been a part of NPRQI before, if you're starting new with us, then I would recommend looking at your entire patient population and entering the entire, doing a sample of that entire population and entering patients into NPRQI that way. And then once you are able to look over your baseline data, if it becomes clear that you are crushing vital signs and pain, but maybe you're not doing so great with your head trauma measures and you want to focus on head trauma, then sampling in the future can focus on those specific areas of focus. But when you start, we recommend casting a really broad net.
Great. Thank you, Sanya, for your answer, and Lisa for your question. Great. So now let's take a moment to recognize the incredible community that's going to be participating in this collaborative. We have a broad range of hospitals that have registered, representing different states, different environments, and different levels of pediatric experience. This diversity is one of our biggest strengths, as it means you'll hear many perspectives and see many different approaches to solving the same challenges. This snapshot gives you a sense of who's here and how much collective expertise we're bringing together for this effort. As of today, we have 150 emergency departments. We had one additional registration this morning across 36 states. So this map helps illustrate the footprint of this collaborative and shows that pediatric readiness is truly a national priority. So we'll be sharing a full roster soon with you all so you can begin networking and connecting with each other. So with the foundation set, let's take a closer look at the types of hospitals that are involved. We have participation from emergency departments with very different resources and patient populations, each type bringing unique insights and unique challenges. What's exciting is that despite these differences, all are committed to strengthening pediatric readiness. This shows the rich opportunity that we have in making this quality improvement work together. We also have participation from emergency departments with very different structures, though the majority are coming from general emergency departments that see both pediatric and adult patients. Though this mix will allow you to see solutions that may spark ideas for your own environment. And here you can see even more of the diversity within our group, whether teams are coming from high pediatric patient volume centers or low pediatric patient volume. Everyone is bringing valuable experience to this network. Some of you have long-established pediatric processes, others are starting from the ground up. Both perspectives are crucial, and the collaborative model allows everyone to learn from each other. Together, this group touches thousands of children each year, and the collective impact of this work we're doing is enormous. And seeing the representation helps us appreciate the scale of what is possible over the next year and a half. One of the strengths of this collaborative is who is participating. We have physicians, nurses, quality leaders, pediatric champions, educators, trauma coordinators, and many who wear multiple hats within their organizations. This multidisciplinary mix is intentional and incredibly important, as pediatric readiness is not a single role. This collaborative gives you the opportunity to learn from people with very different expertise, all again with that same mission. That mission brings us to the goals of our community and Dr. Chumpitazi.
Thank you. So you did a really good job of summarizing all of the things, and we're really excited that you are here to join us and believe in these things. But we really do believe that this shared experience across the diverse settings really helps gain that richer understanding of how to improve performance, because I do think we learn so much by seeing different ways and all the different ideas that we have to bring. We have an opportunity to learn from the shared challenges and different approaches to overcoming those items, and different avenues for support. It might be pharmacy, it might be child life, it might be even your surgeons. Sorry, Erin. And so there's lots of opportunities to improve these measures. And then the exchange of ideas and resources to support one another, how we strengthen and pediatric readiness together through this collaboration. There's just so many amazing outcomes that come from this by building the bigger community. And yes, I was joking, Dr. Jensen, surgeons have been the hugest movement of change and advocates for children. I just really love working with them all. And I'm really excited that you guys will have an opportunity to meet or work with Erica Green too, who's the trauma manager for the eastern part of North Carolina. So thank you so much for this. Let's go on to that next slide. So I will turn it back to y'all. Think about that. What do you hope to gain from this? And if you'd want to go ahead and type in the chat, what was your motivation for signing up? And how can we help you meet those goals? Yep, the performance measures are online. I'm sure Robin's already typing faster than I can and getting those into the chat. All right, Kasey, do you want to close us out?
We again look forward to supporting you over the next year and a half. This is our third cohort of this collaborative, so we have some past experience and what we've heard from past teams who've reported a greater awareness of pediatric readiness, stronger quality improvement plans, measurable improvements in care, and increased NPRQI performance. Many have achieved SMART aims, or their goals, and saw improvement in patient, family, and staff satisfaction, as well as the ability to establish PEC roles. These are things that have lasted far beyond the collaborative and benefited their patients. So these are just some of the tangible benefits for participating and those that we look forward to supporting you all in gaining over the course of the collaborative as well. Now, again, over the course of the collaborative, you will get access to NPRQI tools that'll help you monitor the care delivery and track improvements in your emergency department while enhancing pediatric readiness. We also offer incentives like continuing education credit and MOC Part 4 for physicians and physicians' assistants, as well as certifications of completion for participants. So a little bit about what is next. I will go ahead and walk us through that timeline and our phases of the collaborative so you know exactly what to expect. So our collaborative does run in 4 phases. We are beginning today with our phase 1 of welcome and orientation, and we'll progress through mobilization, improvement cycles, and then again, sustainability and planning in May and June of 2027. Each phase is building on each other. So Let's unpack each phase. In phase 1, where we are today, we're going to encourage you to build your site's team. Attend fireside chats, review our intervention bundles, and get access to NPRQI. This is also time to begin entering your baseline data. This is all about orientation and setup, so you can hit the ground running. Next comes mobilization. In this phase, you'll complete baseline data, take the 2026 NPRP assessment, attend sessions on data sampling, quality improvement strategies, and select your area of focus, and establish your goal. By the end of this phase, your team will be ready to start testing changes. In phase 3, you'll implement change strategies and run PDSA cycles and share your work during collaborative sessions. We'll support you in building data literacy and communication strategies so you can effectively share results with leadership and sustain support. Finally, we'll plan for long-term success. We will be holding monthly collaborative sessions on the 3rd Tuesday at 11 a.m. Central. You can also schedule one-on-one support with our team for questions or coaching, because we want to be accessible and responsive to your needs. To help you choose your focus area, we've lined up topic-specific chats or fireside chats. So these are on February 4th for a pain assessment, February 11th for abnormal vital sign reassessment, February 19th for head trauma, and March 4th for suicide assessment and management. These sessions offer practical takeaways and opportunities to ask our subject matter experts questions so your team can confidently pick your area of focus. And you'll have access to resources to support your work. A number of resources. Did want to, instead of just telling you about where these resources are, but actually take a look at them together so you can help locate them. Change screens here. So I'm going to go ahead and open a browser and head to the EMSC improvement page. This is the EMSC improvement.center. And then going to head to Engage with EMSC, and under Learn About Collaboratives, click on Pediatric Readiness. Once you're there, you'll see that everything you need throughout the collaborative lives in one place. By navigating to our 2026 cohort page, if you've not already seen this section, where you can find our collaborative sessions. This will be the home for all session recordings and materials. So if you're unable to attend a session, you can catch up here. And if you scroll to the bottom of this page, you'll see the registration information for our upcoming fireside chats. Now, again, under our 2026 cohort page, if you navigate to the Collaborative Hub, you should have all received the password to this page via email yesterday. But this is your place to keep up to date and ensure that we're having streamlined communication with our participants to help reduce confusion and make it easier for you all to stay connected. There's a lot of things to find here, including a link to our NPRQI data platform. Important reminders will be under featured updates. And at the bottom here is a great place. We're excited to create a library of resources for you all. So as you begin creating resources and implementing them in your ED, we will be collecting those for you and adding them here so you may all access them. This is also the place to sign up for those one-on-one office hour sessions so we can help answer your questions. Now going back to our side menu, we have our resources tab, which is where you'll find our intervention bundles. So this is your home base for all things for the collaborative, and we will be updating those in real time as things are changing. So lots of resources to help support you along this process. Now, I do want to say thank you all for joining this initiative and for your commitment to this work. We truly appreciate your partnership and commitment. So here are our next steps. You can continue to watch for our weekly email reminders, register for those fireside chats, ensure your team has NPRQI access and has begun entering baseline data. There is a survey after today's session. I ask that you complete that so you can help us tailor our sessions to your needs. You can also take any questions you might have. While we address those questions, I'm going to go ahead and put the information up for today's continuing education credit. So if you have not already, make sure that your first and last name is in the chat. You can either use that QR code or we'll put the link in the chat so you can complete the evaluation for continuing education credit in addition to our survey shared through Zoom. Now there was a lot of information just thrown at you, so happy to address your questions. And these resources and this recording and the presentation will be made available to you on that collaborative resource sessions page, so you can always go back and reference that material. Great. What questions have I missed in the chat, or what questions do you have? Again, feel free to come off mute or use the Q&A feature for your questions, please. I realized earlier I forgot to introduce Lisa. So if you've not already had a chance to meet Lisa, don't know how I missed her in the beginning of today's session, because I'm sure you all have received an email from Lisa. But Lisa, go ahead and introduce yourself, please.
Yeah, no worries, Kasey. Lisa Inosa, I am the program coordinator for NPRQI, and I'm sure that folks, like Kasey had said, have received multiple emails from me. So if you have any questions about the participant organization agreement, anything about the measures, I'm happy to address those.
And she's the master of helping with any kind of POA or outstanding issues too that you have. I'm happy to answer.
Thanks, Corrie.
Going back to the chat to see if I've missed any questions. If I have missed it, if you wouldn't mind just putting it in again, that way we can address your question.
Yeah. And Kasey, you said the slides would be shared on the resource page, correct?
Yes, yeah, you'll be able to find those after today's session along with the recording. Tara, if you didn't receive the password to that, just go ahead and make sure that your ED is registered for the collaborative and that I have your site's information. If you could go ahead and add your ED's name to the chat, and I will follow up with you after today's session.
We know we are over time a little bit, so if folks need to jump or if anybody needs to stay on, I think we're happy to stay on and answer any direct questions.